All right, so we can get started here. Let's talk about pulmonology. So I'm not going to get too in deep on the and the infectious disease side of things. I really want to kind of more focus on the actual drugs affecting the pulmonary tract itself. But if you have any questions, we can always go off script if need be. That's totally fine here. Okay. So anyway, so some of the meds we want to cover here. What are we talking about, right? So we have our beta agonist. What do beta agonists do? They bronchodilate, right? How do they do that? Wow, that's getting pretty in-depth there. Yeah, so increase cyclic AMP. What does that do? Actually, smooth muscle relaxer. It gets less calcium into the cell there, right? So similar to how you would think about like a nitrate helping to relax that smooth muscle to cause hypotension or to relieve chest pain. You're kind of doing the same thing a little bit. Now, which beta receptor am I talking about specifically? Exactly right. You got one heart, you got two lungs, so beta 2 typically you think about more for the lungs. Good. So, and again, good for helping to reverse that bronchoconstriction you see with asthma to relax that smooth muscle, right? So what's the kind of the typical agents you'd run into? They're on the slide, right? So albuterol is kind of your bread and butter. You're going to find that in most asthmatic patients. A lot of other patients are going to have this available to them. How would you use albuterol typically? Like how often? How would you dose it? What do you think? So you think like 1 to 2 puffs? Probably a little more than that. Usually at least 2 puffs, right? Typically going to be doing there with that drug. But it also depends on the route you're going to be giving it, right? So what are the different ways I can give albuterol? Yep, so meter dose inhaler, right? So it's an MDI. That's going to be the one, the canister that has a propellant in it, right? Kind of what you see right here. What else? Nebulizer is another very common one. Where would you might use a nebulizer more commonly? Yeah, typically at the ER, like an inpatient sort of setting there, you're more likely to find the nebulizer being used. Any other ways to give it? There's actually an oral syrup they used to use more commonly back in the day, but it's a very old school kind of thing. You saw a lot of issues with it. Why do you think? Where do you think the issue would be with an oral albuterol you'd ingest versus like an inhaled form? A lot more side effects due to the systemic administration of it, right? So again, we'll talk about side effects of these in a little bit. So there's albuterol, right? So if you were to split out the enantiomers and only take out the left-handed form of albuterol, then you have levalbuterol, right? Anyone know the brand name for that? Never heard of it. Here's Xopenex. That's what they're referring to. Xopenex is levalbuterol. Now, why would I just want to use one of the enantiomers versus the racemic mixture? Yeah, I think it has less side effects, right? I think it does. I don't know. I don't know if studies are really borne that out. But when you're thinking about equivalent doses between the two, so say, for instance, I wanted to nebulize, say, 5 milligrams of albuterol, what does an equivalent dose of levalbuterol be? Right, it's just half, right, because it's just one of the enantiomers. So 2.5 milligrams of albuterol, levalbuterol is equivalent to 5 milligrams of albuterol. So it's good to keep that in mind, because if you have a patient who comes in to the ER and they are on Xopenex at home, but you don't have Xopenex because it's expensive and it's not in the formulary, and you write for it, but then the pharmacist calls you up and says, "Hey, you can't have that." And you say, "But I'm the provider. I get what I want." And I say, "No, you don't." You say, "Okay, I guess I'll use albuterol." You need to convert that, right? Now, hopefully the pharmacist will give you an easy conversion dose, but you can know that already because you know the relationship between those two drugs. Now, the next two we have here, formoterol and salmeterol. What differentiates these from albuterol? They're long-acting forms, right? So again, you may sometimes see them by themselves being used. And when we say long-acting, how long are we thinking here? Usually around 12 hours or so, right? Most of our inhaled meds you're going to be seeing more of the long-acting forms, typically twice a day. Twice daily dosing you're going to see for a lot of these. So formoterol, salmeterol, typically twice daily. Now, do we use these by themselves in asthmatic patients? Typically, no, right? Typically, we're going to add that steroid to that. And the reason why is they actually found that there was an increased risk of death when used by itself for asthmatic patients. Now, these do come by themselves. Who much use that for? Yeah, COPD patients are more likely to get that by themselves, so just be aware of that. If you ever see an asthmatic patient on, formoterol by itself, that is inappropriate, right? They need to be on a steroid along with that, and so we'll talk about the different treatment strategies in a few minutes here. Good. We have our anticholinergics, right? So what are these going to do for us? They can help with secretions, which we know they get more copious than when you have, an airway reaction that leads to bronchoconstriction. That mucus production comes up as well. What else can that do? It does help out kind of relaxing that smooth muscle as well. So kind of both have the ability, and which is why very frequently you'll see both given together, albuterol and ipratropium, right? Sometimes you call that a duo neb or combivent. Sometimes you'll see that. They're actually the two being used together. Now, with most asthmatic patients for their chronic at-home sort of dosing there, do you typically see them on an anticholinergic like ipratropium? Typically, no, right? Typically, they'll just have their albuterol as a rescue inhaler. They won't be on the anticholinergic. Why that is, who can say? It's probably not all that too efficacious or additionally efficacious. However, when would you see ipratropium being used? So you could use it in COPD. You can also use it for asthmatic patients, but think of the clinical setting where you might use it. Typically in the ER sort of setting or an inpatient setting, you'll find the two being given together. So if I have a kid who comes in who's having an asthma attack, oftentimes they're going to get albuterol and ipratropium together times 3 doses. So if you see like, albuterol 2.5 milligrams, ipratropium 250 micrograms, Q15 minutes times 3 doses. That's a very typical sort of order you might run into or you might write for your patient. Now again, you get Q15 minutes. It's going to be nebulized. So again, the RT will come in, see how they're doing after the first dose, may give them another treatment, see how they're doing after that, give them another treatment, right? So that's typically what you'd normally see there. Now there's a long-acting anticholinergic as well. Anyone remember what that one was? It was tiotropium, right? That was a Spiriva. That's what's typically used to COPD patients, more kind of long-term. Would I use Spiriva in an asthmatic patient? No, you would typically not do that, right? Long-acting anticholinergics don't really have a good place in management of asthma, as you'll see. Now, anyone know how you can like test someone to see if they have asthma? Like, sure, they can present, they can have all the signs and symptoms and the history to make you think, yeah, it's probably asthma. Is there any way you can actually induce an asthma attack? Never mind. Provocation testing, good. So we're going to provoke an asthma attack. Anyone know what you use for that? So what could agonize those muscarinic receptors in the lungs? Normally, they're muscarinic receptors, so what neurotransmitter hits that? Acetylcholine. There's actually a drug called methacholine that we use to actually provoke an asthma attack. So you can actually do that for patients if you see their FEV1 go down in response to that methacholine, and then you give them albuterol and then it reverses, then you know, hey, it's probably very likely to have asthma, right? So actually I have a cousin who just recently went to get that. He always thought he had bad sinusitis, chronic sinusitis and allergies, but it may turn out he had asthma. Who knows, right, if he was never properly diagnosed. So it makes sense. I can give a cholinergic agent to induce an asthma attack. I can give an anticholinergic to help reverse some of that as well. Okay. Now, did you have a separate question, David?
No.
Oh, okay. Now, some other treatment options we have available to us. We have the leukotriene receptor antagonist. This is mainly going to be montelukast. Anyone know the brand name for this? Singular, right? So where does this fit into the treatment? Someone speak up a little more. Okay, you can use for exercise-induced asthma. Okay, what else? Yeah, so you can use from asthma-like symptoms, but typically is this like a short-acting, like quick medication? Is it long-acting? Yeah, it's going to be more long-acting, right? So you want to think about this in terms of other long-acting medications like your corticosteroids, like your long-acting beta agonists. Typically, some patients may just be managed with leukotriene receptor antagonists like montelukast at nighttime, and then they'll have a rescue inhaler in addition to that, right? But again, this is not a quick-acting medication. It's going to be more chronic. Any big side effects I worry about with montelukast? Stuff's pretty benign for the most part, and we'll see plenty of kids, especially who will be put on this for more chronic management. Additionally, the benefit of using this is that you may not have to use a corticosteroid for those patients, and there are some concerns which we'll talk about a little bit there. But again, most of the time you're going to find most patients will do a little bit better with the corticosteroids. This isn't going to be quite as effective as you'll see there. What other agents do we have here? So we have our enteral or parenteral corticosteroids. Enteral just means take them by mouth, right? You take them orally, right? And parenteral, injectables, right? So IM, IV, whatever the case may be. So we have prednisone and prednisolone. Anyone know the relationship between those two? How does prednisone come versus prednisolone? Anyone know? Good, right? I'm sure you heard this, especially in maybe like in pediatrics with Dr. Nicholson, perhaps you mentioned this. Yeah, prednisone is a tablet form. Prednisolone is a liquid form, so most kids are going to end up taking the prednisolone. Actually, prednisone gets turned into prednisolone in the body. It gets converted over, and that has its actions there. We have methylprednisolone. Anyone know how this comes? You have to think about like a Medrol dose pack, so there is an oral option available, but very frequently on the inpatient side, you'll see this gets used quite a bit as well. So you'll actually have little vials. They're kind of cool looking. They call Actidose vials. Or basically there's a liquid portion at the top of the vial, and then there's a dry powder at the bottom. That's the actual drug. You squeeze down on the vial, and it actually mixes the two together, and then you can draw that up. So methylprednisolone is a common one you're going to see like that. Good. And then you also have dexamethasone. Anyone know how that's given? Has oral and IV options that are available as well, right? So really the only ones that does not have a parenteral formulation is going to be the prednisone and prednisolone, right? Any of the other ones can be used IV or IM. What do you think is the difference between these corticosteroids? Is there anything at all? Typically, duration of action is going to be longer for dexamethasone, and so I'll give you an example of how you might dose this. So anyone know the dosing for methylpred or prednisone for a child? And we like look it up real quick in their Terrascon. Maybe you can find it. Again, how about for a kid? Dosing? Oh no.
Unapproved feeds would be 0.5 to 1.7 milligrams per kilogram.
Okay, so 0.5 to 1.7. That's kind of hard to remember. What could you just remember? One, right? If it's one, it's a lot easier to remember. Most of Pete's stuff ends up coming down to like 1.1, 0.01, whatever the case may be. Yeah, so typically you might imagine like prednisone or prednisolone for dosing it for a kid, usually 1 mg per kilo, either once or twice daily. So really the dosing can be 1 to 2 milligrams per kilo per day, right? So per day, I can divide that up either once or twice. So, and again, if I had to say a 27 kilo kid, what would I dose him at? And knowing it's between 1 and 2. I can bump them up to 30, right? You can round the doses pretty easily if you have those kind of ranges you're working with. So a 27 kilo kid, I give him 30 milligrams of prednisone or prednisolone. Either way is totally fine, right? Because you're still within that range there. Anyway, so let's say I was going to do 1 mg per kilo per day for 5 days for an asthma exacerbation or prednisone, right? It's a very typical sort of thing you're going to see there. Do I have to worry about tapering when I use prednisone like that? Why not? Too short a course, right? If it's anything less than a week, I'm not too worried about that, right? Now, those methylprednisolone dose packs, you'll see they already build in the taper into it, right? You take 6 tablets on day 1, then 5 and 4 and 3 and 2 and 1, right? You don't have to do that. It's not strictly necessary. But let's say, for instance, prednisone, I'm doing 1 mg per kilo per day for 5 days. To give you an example of how dexamethasone has a different half-life, a much longer half-life, for dexamethasone, I can actually just give 2 doses and give them about 36 hours apart. And so if you look up dexamethasone, you might see it's like 0.6 milligrams per kilogram. You'll typically max out at a max of 16 milligrams. You don't want to go above that. And I give that as 2 doses. So basically I'll give them 1 time in the ER or 1 time in the clinic, and then I give them a prescription for 1 more dose on the outside. They'll take that about 24 to 36 hours later, and that will cover the same 5-day period as the prednisone will. So what's the benefit of that? Better compliance, right? Again, if you've never given a child medication, I will bring my children in here and see if you can give it to my 3-year-old. You'll probably end up with a black eye, possibly a crushed larynx when she kicks you. Like, it's not great, right? So again, if I can give 2 doses of a drug versus 5 doses, that could be beneficial, right? So compliance can be an important thing to consider there. Yes, David? Yeah, so if you see like a sodium Medrol dose pack, that's the taper's already built into it. So it'll come as like a little cardboard sheet. Basically, you just kind of pop up the tablets. I think it's like 6 on the first day and then 5, 4, 3, 2, 1. Yeah, that's a really good question. So you wonder, how do I actually write that out? So you want to do a sodium Medrol dose pack, or Medrol dose pack. Basically, with that one, it's a pretty well standardized sort of thing, right? We've been using it for decades. What you can actually do is write for like a Medrol dose pack and say use as directed, because that one has very specific instructions on it. It tells the patient exactly how to take it. That is a case where you could say use as directed, and that's appropriate, right? Because it's already built into there. Now, if you wanted to, you could write in the taper yourself, especially if you want to, like, say, go off script, so to speak, and do it your own way. If you wanted to, you could do that. You could write, say, day 1, take this many milligrams. Day 2, take this many milligrams. Or you may say, take 1 tablet in the morning and 1 at night. Or and then as you go down your taper, you can make it specific for that patient there, and all of it will show up on the bottle when they get it from the pharmacist. Yeah, good question there. Anyway, right. So again, these are good. Why do we like corticosteroids? What are they going to do for us in terms of asthma? decrease inflammation. They're going to decrease all those cytokines being made, all those neutrophils going to the area. They're going to decrease that edema. They're going to decrease that inflammation, decrease that mucus production. Is this a quick thing? Not super quick, right? So again, it's going to take a little bit of time. This is better for those late phases of the asthma reaction. Remember, there's an early and a late phase. The albuterol is going to help out with the early phase, but they could have a reaction several hours down the road, and this is where corticosteroids come into play here, right? Because where do they work? Actually have to work in the nucleus of the cells to actually decrease transcription of those inflammatory cytokines and all those products and whatnot. So again, it's a slower process, but much more powerful than you will see with just an albuterol by itself, right? Because again, it works at the very tippy top of the pyramid of inflammation. However, there's a lot of side effects that go along with it. What does that include? Yeah. Immunosuppression, right? So that's going to, and again, do you think that's a big concern when I have, it's like a 5-day course, prednisone? Less likely, right? It could theoretically be a concern, but less likely. However, if it was already in someone who's immunocompromised to begin with, maybe they're on active treatment for cancer, maybe they have HIV, maybe they're on other immunosuppressants, already, that could be a concern, right? That's more long-term, those when you typically think of that. What else could you see? Hyperglycemia is not great for your diabetic patients. What else? Blood pressure is going to go up, right? So not good for hypertensive patients, potentially. Anything else? What about your mood? People get kind of cranky when they're on steroids, right? It's not everyone, but they typically have a little bit of mood alteration. May not be quite as friendly as they might be on a normal day-to-day basis, right? Somebody accused me of being on corticosteroids this past month or so, but really that's just all the cortisol I'm producing from trying to sell and buy a house at the same time. So there you go. When you only have 10 minutes to get your house ready for a showing, it's a little stressful, right? So again, this is how these things pop up. Anyway, not that I'm like projecting onto you guys my feelings. Anyway, so those are the systemic steroids we have there, right? Either parenteral or enteral, right, as the situation may call for. Next, we have our inhaled corticosteroids, right? So there's a lot of them, a lot more than what I just put here. These are the common ones that I see, though. Fluticasone, budesonide. Now, will you see these by themselves? For asthma? Yeah, 100%. Yeah. So again, when you're looking at Flovent, that's the brand name for fluticasone. Now, where else can you use these corticosteroids? Can you just use them in the lungs? Yeah, a lot of them have nasal formulations as well, right? So this is a common thing to get mixed up when you mean to write for fluticasone nasal spray, but you accidentally write for the inhaler form, right? The inhaled form, because again, it's Flonase versus Flovent. They're easy to mix up by providers, and again, it's a very common medical error to screw that up. Or if the say like a nurse is doing like a medication reconciliation, taking the medication list from the patient and they miskey it or something like that, that's a very easy mistake to put in there as well. But again, most of these are going to have a nasal formulation available along with an inhalational form for asthma or COPD, just kind of any kind of long-standing inflammation. So fluticasone, budesonide. Budesonide is nice in the inpatient side because it comes as a nebulized product, so you can actually use that. If you have patients who have a hard time maybe using an inhaler, as you might find, we'll talk about technique in a little bit here. But those are good to use. Now, what are their place in therapy for asthmatic patients? Right. So short-acting beta agonist, is the intent when you have that to use it around the clock? You shouldn't, right? It's only going to be for the intermittent symptoms. So again, if you look at that pathway, if you look at the different gradations, we have like your intermittent asthma, your more mild, persistent, moderate, severe, persistent asthma. Again, where do the corticosteroids come into play? Right, for the persistent symptoms, right? So again, that's going to be your baseline there, because again, you want something for around the clock coverage, and then the albuterol is going to be, it's almost like having like your nitroglycerin for chest pain, right? It's going to be as needed. If it comes up, you can use it. And the goal would be, how often do you want to have them use their albuterol inhaler? 0 would be ideal, right? That shows that their inflammation is very under control and they don't need to use, they're not having the symptoms requiring use of the albuterol. Okay, so that's the goal. It'd be very nice. I remember I was an asthmatic child growing up, and before I was well controlled, I had an inhaler with me all the time in my pocket, all the time. I would use it. I didn't realize how out of control I was because I was a child. What do I know, right? However, as soon as I get put on Advair, you know what Advair is? A mixture of fluticasone, which is a corticosteroid, plus salmeterol, which is a long-acting beta agonist. All of a sudden, I was like, wow, I don't need my inhaler anymore. This is fantastic, right? Because again, I had 24-hour coverage. The inflammation was under control from the corticosteroid. The long-acting beta agonist was keeping the smooth muscle relaxed for most of the time. I actually did not need my inhaler. I was able to leave it at home, not have to have that with me, right? So again, you're going to find that ideally these patients will not use their inhalers at all, but they still need it occasionally. How could you tell if a patient was really out of control in terms of using their albuterol inhaler? Coming in for refills too soon, right? Or they get issues where the insurance company doesn't want to pay for it because they say, hey, it's too soon. You just got this like 2 weeks ago. You know how many doses usually come in those meter dose inhalers? Usually about 200, right? So it means 2 puffs at a time typically means it's 100 doses. So if you use 100 doses and say, 2 weeks or something, that shows you're using quite a bit, right? Your symptoms are not controlled very well. So that's a very good sign. Hey, are these patients, do they need something tuned up in terms of their long-acting medications to help out with that? It's a good way to know that. Okay. Next you have, and again, there's other inhaled corticosteroids. There's mometasone. There's, I'm trying to think of any other ones off the top of my head. There's a lot of them that are out there, right? Betamethasone, I believe, is one. You'll find a ton of them. But getting into the miscellaneous agents, other pulmonary things we have here. So we have things like magnesium sulfate. Why would I use an electrolyte for treatment of asthma or any respiratory disorder? Think about magnesium. Yes, sir. You can use it for status asthmaticus for sure, right? What is status asthmaticus? It's like, you know what it is, but like it's hard to describe it, right? This was really continuous, very severe asthma attacks, right? Where they're unresponsive to things like albuterol and whatnot, right? So again, when they're unresponsive to those normal therapies, so we kind of consider that status asthmaticus, right? So magnesium, yes, you would use it there. What does it do for us? It's just for electrolyte replacement. Like, do people who are hypomagnesiemic become asthmatic all of a sudden? No, but magnesium is a smooth muscle relaxer, right? Very similar to how it almost works like a calcium channel blocker, right? It kind of prevents calcium from getting into those smooth muscle cells and will relax them, which will go along with one of the big side effects. If I give someone a big bolus of magnesium, anyone know what kind of side effect I might see from a cardiovascular standpoint? If it works like a calcium channel blocker? Hypotension, right? We very frequently have to give fluids along with the magnesium in order to help prevent the hypotension from developing. So very frequently we'll have paired orders. We'll see like say 2 grams of magnesium sulfate IV plus say a liter of normal saline to go along with that, right? And so that way that helps to prevent the hypotension from developing. But the main thing is we're using that magnesium to relax that smooth muscle. We normally use it at a dose of about 50 milligrams per kilogram up to a max of 2 grams, right? Typically don't want to go above 2 grams in any dose for adults or otherwise. And that will help to relax that. So it's very good. Sometimes we'll actually put them on a continuous infusion afterwards as well. So if we see some response, then we'll put them on a continuous infusion. That's typically those patients get admitted or go to the PICU typically. Okay. If you have to give a patient magnesium in the ER for their asthma attack, typically they're not going to be the ones that are going home, right? They probably need to at least come in for obs, even if they respond pretty well to the magnesium. But it depends on where you're practicing. How about racemic epinephrine? What is that used for? Another pediatric indication. I don't give a croup. There you go. Yeah, so croup is a very common place we're going to see that. Again, croup is typically caused by what? Not RSV necessarily. It's just like a parvovirus. You can normally see that. But basically, it's a viral upper respiratory tract infection where they get that stridor that happens there. Again, that is showing that you have laryngeal edema happening. That racemic epinephrine is going to be able to help relax some of that, right? Because again, epinephrine acts on which receptors? Alpha-1, also beta. Our bodies release epinephrine all the time. What do they interact with? We know this. Beta-1 and beta-2, right? They act on all the receptors, right? It's an endogenous catecholamine. It's going to interact with all of those, right? So epinephrine is going to be good to help kind of decrease that swelling there, decrease that stridor that happens. So typically it would be for more of those severe and cases of that laryngeal edema. So we'll use that as a nebulized formulation. Anyone know what else you give along with the racemic epinephrine to do with that inflammation? Absolutely, dexamethasone is a very it's a common combination there. So if you have a kid who comes in, you're suspecting croup, they have that really barky coughing here all the way throughout the ED, you'll end up giving them dexamethasone. If they still not really responding to that, then you actually will give them the racemic epi, right? Or if that shows that they're hypoxemic or whatever the case may be, if it's more severe, that's where they get the racemic epi. Okay. How about ketamine? I think ketamine, why is that good for asthmatics or for pulmonary issues? Good as no respiratory depression, but do I just give it to any asthmatic that comes in? It's like, you need some ketamine. Status asthmaticus is good. In which case, though, like at what point would I want to consider using the ketamine? If you, yeah, if you need to intubate is when we're gonna pull that one out, right? So if we need to intubate these patients, which can happen occasionally. So again, if they're not, and again, something you'll see with these status asthmaticus patients, depending on how long they've really been working up to it, they can tire themselves out, right? So a point where once they tire out, they're not going to have that good respiratory drive anymore, and they will then crump, essentially. So that's when we can intubate and help to take that over for them. And so we can use something like ketamine as a sedative. Again, when you do rapid sequence intubation, excuse me, my phone's not on silent, which is very inappropriate. When you are intubating a patient, what are the common medications you'd use for that, right? Class-wise. Typically, you want to knock them out with a sedative, right? And then what do you give them? Paralytic to relax those muscles. So that way you can get a good visualization of the vocal cords and you get that tube pass, and they're intubated, right? So instead of using something, and what other sedatives could we use for intubation? Etomidate is a very common one. Propofol is a very common one. Sometimes Versed is used or midazolam is used, but you can sometimes use ketamine here as an alternative because one, it doesn't affect the respiratory drive, which is great, but also it kind of naturally causes release of catecholamines like epinephrine, norepi, and so by doing that, it will interact with those beta-2 receptors and cause some bronchodilation. It'll also cause their blood pressure to go up a little bit, heart rate to go up a little bit. However, anyone know what happens to heart rate when you're doing laryngoscopy on a patient? Typically have a vagal response. Actually, can cause bradycardia in those cases. But so sometimes it can help out with that. But the point being is that ketamine is a bronchodilator, and I would make that recommendation if I had a patient with severe asthma and they're getting intubated. I'd say, hey, maybe ketamine might be a good option. You can use that as a continuous sedative for those patients there. So that's a decent one to think about. And remember, like the bad side effects of ketamine. It's the dysphoric reactions, right? So it's when you go down the K-holes, as they call it, where there's really bad dysphoric reactions when they're coming out of it. So again, always think about that. Also, vomiting is pretty common when patients are getting ketamine. So sometimes you want to treat them with an antiemetic, such as Zofran, otherwise known as ondansetron. What's the dosing for that? Anyone know? You do 4 up to. You do up to 8 milligrams IV, right? Sometimes these cancer patients will get up to like 16. How about pediatric dosing? Again, always a safe guess is 1 mg per kilo, but in this case that would be a wrong guess, but it's always a safe guess. But 0.15 per kilo is a good dose for a pediatric patient, right? So anywhere between 2 and 4 milligrams typically for those little guys, right? So we'll give that sometimes to kind of cover ourselves, make sure they don't vomit, because the risk of vomiting when you're trying to intubate a patient is aspiration, right? Then you have a chemical pneumonitis on top of everything else, and it's not good, right? So those are the things we're trying to avoid there. Good. So let's talk about technique in terms of educating patients on how to use their inhalers, because very frequently you'll find with patients who are not well controlled with their asthma, you'll find their technique is pretty lacking, right? So why is technique so important? So where does the drug go if it's not getting into the lungs? Either they're breathing it out potentially, right, when they exhale, or where else might it go? Down to the GI tract, right? They actually have there's some interesting studies that are out there. I don't have any pictures of it, but there is a study where they had actual albuterol that was laced with a radioisotope, and they were testing patients to see where the drug was actually ending up, whether it was actually in the lungs or in the back of the throat or down into the GI tract, and actually found that based on the technique, like you can get a significant amount of drugs that are just going down to the stomach, and that's not really where the drugs are going to be working all that well, so it's not really beneficial. So sometimes you may say, well, are you compliant with your long-acting inhaled medications? They may say, yeah, I'm compliant, I take it just like I'm supposed to, but the technique may be lacking, and that may be leading to them not getting a whole lot of good effect from it, okay? So we have 3 main types of inhalational products we're going to be seeing used there. We talked about the meter dose inhalers, right? Does that have a propellant or not? So typically you think a typical inhaler. That does have a propellant in it. So as soon as the patient presses down on the canister, medication is going to be coming out, okay? As an alternative to that, there's what we call a dry powder inhaler, okay? DPIs, which you might see that. So if you ever see like an Advair discus where they have to spin it to open it up, that will have basically little tiny pockets of medication that they will pierce There'll usually be like a little trigger on it they can press, and that will then pierce and open up that medication. And then who is providing the propellant at that point? The patient, right? They have to have good inspirational force, right? Not like the inspirational force that I exert on all of you, but the inspirational force to actually get the drug into their lungs, right? So who might have problems with that? Kids may have a harder time with it. Older patients may have a harder time with it. So you have to think about, like, hey, can they even get a really good breath in to draw that medication? If they can't, it's probably not going to work all that too well for them, right? So this is where dosage form really matters. And then getting into the nebulization. What's the problem with using a nebulizer potentially? Well, again, nebulizer is kind of like using a shotgun sort of approach, right? You're putting the liquid into the nebulizer cup. You turn on the pump, right? It's going to the compressor. It's going to nebulize that drug, and it just kind of comes out, right? Patients will breathe it in passively, which is good for who? Maybe little kids who are not being all that compliant, maybe older patients who don't have the coordination to use a meter dose inhaler. However, though, you're getting a lot of extra drug. And so you're more likely to see systemic side effects when you're doing that, right? So again, using, and just to give an example, a typical nebulized dose of albuterol is between 2.5 to 5 milligrams, right? What is a typical dose given via meter dose inhaler? It's 90 micrograms. Right, so 2 puffs would be 180 micrograms those patients are getting versus 2.5 to 5 milligrams. Which one do you think would be more likely to cause side effects? The bigger dose, right? Because again, you're just getting so much of it. And I remember when I was a little kid, and I'd have, say I get like a respiratory infection, and I'd have to go on my nebulizer because the inhaler really wasn't cutting it at the time. Of course, my brother and sister would make fun of me because I had to suck on this big nebulizer thing, for 30 minutes at a time. It was very embarrassing, but I was also at the end of it very jittery, right? Because again, what's the big side effects of albuterol? Get palpitations, right? Because your heart rate's going to be up because you're having some bleed over effect on the beta-1 receptors. The skeletal muscle gets affected by those beta activations, so it causes tremor. Feel very jittery afterwards, right? So again, you feel those side effects much more when you use the nebulizer because you're just getting so much of a bigger dose than you would get with a typical meter dose inhaler. Okay. Anyway, so going back to the meter dose inhalers now, how would you educate a patient? How would you tell them to actually use an inhaler for the first time? Would anyone like to volunteer? Say how you would educate a patient. Keep in mind, I have the randomizer at my disposal. Okay, so how would you educate?
Okay, so you want to sit up straight, like you don't want to slumping or anything.
Okay, good. So posture is good.
Yeah, so posture, and then breathe out, and then as you push down, you breathe in.
Okay. And then what do you do? Then you don't know? They just breathe back out?
Oh no, and hold it.
Good. For how long?
30 seconds.
Oh my goodness. Can any of you hold your breath for 30 seconds? You're all young, strapping individuals, but I don't know if I could. Yeah, so here's how I would, that's very good, right? So very nice job. What I would mention as well is that one of the things you want to do is kind of have the patient start that stream of air before they actually press the canister. So that way the drug will basically enter that airstream, and you have more likely of it to actually end up in the lungs versus the back of the throat or into the stomach, right? So what I would say is that yes, you expel your air, right? Expire your air, and then as you're breathing in, then you depress the canister, right? Breathe in nice and deep, and then hold it till the count of 10, right? That may not really be 10 seconds, but I try to say, 1 Mississippi, 2 Mississippi. Not everyone can hold it for 10 seconds, especially if they're in the middle of an asthma attack, but that is the goal, right? They count to 10, and they breathe back out, and then they're good to go. Now, should they do 2 puffs at one time? Why not? You think about it, you want the drug to have some time to work, right? So I'll use the first puff, have them hold it in 10 seconds if they can, and that's going to start to open up those airways. And then by the time they get the second dose in, say they wait 30 seconds, 2 minutes, something like that, that will then allow the next dose to get that much deeper in and to work that much better. So again, some people will try to use both doses at the same time. Not recommended. I have them at least separated out by at least a minute or two. In those cases there, the first dose kicks in, second dose works even that much better the next time. Okay, so that's how I would recommend. And then how about like cleaning? Do you have to worry about cleaning your inhaler? Yes, because again, your grody mouth is on it, so again, you don't want stuff to grow over time, other viruses and fungi and all kinds of stuff. So basically have them clean it out every once in a while, make sure they're using just soap and water is totally fine for that. Okay. One other point that we didn't mention, when you're using a meter dose inhaler, what do you need to do beforehand? Got to shake it up. Why is that? You'll typically find the drug and the propellant will kind of separate out a little bit. So by shaking it up, that way they'll go ahead and get mixed up. So have them just shake it up for a couple times, and then they'll go through that process. Okay, that's basically how you recommend patients use their metered dose inhalers. Now, on the other side, let's say we're using a dry powder inhaler, a little bit simpler. All you have to have the patient do is say, open up the drug. If it's like a discus, they'll basically just kind of spin it open. They'll depress the trigger that will then pierce the drug containing packet there. And then what do? So have them expire their air, breathe in very forcefully if possible to try to get all that drug in. Because again, they're the only ones providing that force to actually get the drug into them at that point, right? There's no propellant in those dry powder inhalers. And then again, hold it for about 10 seconds or so. Okay. Now, usually you're going to find the corticosteroids are typically the ones you'll find most often in the dry powder inhaler form. What also do you have to recommend to those patients who are using corticosteroids? Wash your mouth out afterwards. Why is that? Why would you get thrush? So thrush is just what? Candidal infection, right? So why would I get a candidal infection in the back of my throat by using a corticosteroid?
It's suppressing the local area of the immune base, so it's just opportunistic infection.
100%, right? Basically, just the same reason why HIV patients get thrush, right? Because it's an opportunistic infection. You're causing a local area of immunosuppression with those corticosteroids. Thus, the thrush finds can get a little foothold there. Now, again, if you have a typical asthmatic patient with no other comorbidities, am I really worried about like systemic fungal infections from there? No. If I needed to treat, I could use something like a nice statin oral or something like that. That's very easy. You know, it doesn't get absorbed systemically. Not a big deal, right? It's more kind of just troublesome to the patient to see these big white plaques on the back of their throat. But again, by having them just wash out with water. Now, would you recommend soap and water? Unless they're using swear words. But otherwise, yeah, just water, right? Just water. Just kind of swish their mouth out afterwards, and that will get rid of any excess drug that might be there in the back of the throat. Okay. So those are pretty common techniques there to think about. And again, think about the common side effects. Now, do you get a lot of side effects from, say, the inhaled corticosteroids? Not typically, right? Besides the thrush, that's really the biggest thing that I would educate patients about. Make sure you wash your mouth out. Otherwise, you might see these white plaques that start to develop there. And then when they come back to you and they say, look at this white plaque I had. And you say, I told you so, right? Maybe not in so many words, but you'll basically say, yes, that's exactly what I was talking about. We'll know about it. Albuterol side effects, we know the common ones there. Usually the palpitations, the tremors, things like that. Less likely to see that with, typical meter dose inhaler unless they're using a lot of doses in quick succession. How about spacers? When do you use spacers? Like when I'm going to Coco and I'm going to go to NASA and take off. Use a spacer there. So spacers are good. Another name for them is valve holding chambers. These are good for patients who have a problem in terms of coordination using that meter dose inhaler. Basically, it looks like a big plastic tube you'd be attaching to the end of the meter dose inhaler. You depress the canister. The drug then gets held into that chamber, so I don't have to worry about the patient coordinating their breath versus actually pressing the canister there. And so then they can breathe it in as they need to. And typically it is designed to where they can't breathe in too fast, otherwise it will make this kind of whistling sort of noise there, and then they need to slow down their inspiration a little bit there. Okay, so who might that be good for? The patients like coordination issues, right? So again, if they were maybe having some issues due to like osteoarthritis or rheumatoid arthritis or something, and they can't really coordinate very well, that could be a good case there. Sometimes children will be fine there. That's the big things to consider. Okay. Any questions on that stuff so far? Okay, I think I have some cases to go over here. And again, just kind of listening at treatment options. I want you to think about these when we start talking about the cases and what kind of medications we're going to use. One, think about dosing, think about how we're going to be using these drugs here. So let's do a 10-minute break. We'll come back and then start talking about some cases. Any questions from the first half? How we're using these drugs, kind of their general place in therapy. All right, so let's do a couple of cases. These are just through... it wasn't Access Medicine, but there's like a case files series which I was pulling from. They have a couple different books, which is good. We were going through, and I think Professor Q is doing something similar to this, correct? Okay, yeah. So they're quick cases, little vignettes. We can talk about some of the things about how we would think about treating these patients, and then write some scripts for how we're actually going to, what we'd actually write for in an actual clinical situation. And then I can, again, pull random victims. Willing participants to come write scripts on the board for us, hopefully, right? Maybe, we'll see. Anyway, So let's talk about some agents used to treat asthma first off. So we have an 8-year-old boy. He's coming to office. He's got chronic cough. Again, you guys can read this, and you got the links to it, right? So you can get to the thing itself. But again, is waking up 2 or 3 times 2 or 3 nights a month as well. So Artie, what are you thinking in terms of classification? All right, mild persistent, right? Because again, it's having several, a couple of wake ups during the night. So again, it's not really an intermittent problem. It's already into the persistent issues here. Okay. Anyway, notice it's kind of worse in the spring and the fall. Usually when you're getting some more pollen and stuff like that in the air. He's been treated for bronchitis in the past with antibiotics, cough suppressants, but things never tend to clear up completely. Exam was notable for those expiratory wheezing there. Okay. So I say, okay, you have asthma. How do you want to dose this inhaler for this patient here? It's albuterol inhaler. So who would like to write the script for an albuterol inhaler for this patient? Anyone at all? Everyone's pulling out their Tarascons. Say, how am I going to do this? Kyle, would you have to come up? Again, I don't want the usual suspects here, so I'm going to have some others come up here as well. And then again, we'll talk through the process, and we'll talk about what we want to see there on the script, what we want to look for. Okay, so first off, what do we need?
Albuterol.
Good, so your albuterol. What does HFA stand for? You don't know? Nicholson said to put HFA. You wrote it down. Fantastic. Okay, well, so HFA is actually the propellant that they use in there. The reason that several years back they had to switch out all of the propellants because, again, and I don't know how clinically significant this was in terms of ozone depletion, but they had CFC-based propellant. And I said, I mean, really, are all these little asthmatic kids like actually depleting the ozone with their inhalers? I don't know, but they decided they're going to take out the propellant, switch it out to this HFA, and so they also got brand new patents on all of those inhalers. So guess what? Now everything's brand name again and super expensive. Wah, wah. So that was unfortunate, right? But that is the propellant they use. You could also write what else instead of HFA? MDI is fine as well, right? So meter dose inhaler. Yep, so you could write that. So, and again, these meter dose inhalers, typically what kind of dose are they administering? So yeah, you'd say how many puffs you want to give, but typically how big of a dose is that per puff?
2.5.
Actually, no, it's 90 micrograms, right? 2.5 is that nebulizer dose. Okay, so again, keep that straight because you can write scripts for a nebulizer, right? And then in that case, there you would say, albuterol nebulizer solution, 2.5 milligrams, Q 6 hours is needed for cough, wheezing, whatever, right? So for this one, we want to say, okay, in fact, when you write for an albuterol MDI, you don't really have a choice in the dose, right? It's always going to be the same no matter what you're writing for, okay? Now, there's other brand names as well. There's Proventil. Anyone know any other ones? Huh? So Acuneb is typically the nebulizer solution, so that would be kind of more in reference to that. There's Ventolin. There's ProAir. Those are your 3 big ones: Proventil, ProAir, and Ventolin. Now, why might that make a difference for your patient? What kind of insurance coverage they have. They might find that one is preferred over another. So sometimes by not putting the brand name in there, that is helpful because sometimes the pharmacist will try to fill it for that particular brand name. Their insurance doesn't cover it, then they're going to get kind of an error there, or they'll have to talk to the patient, and they might have to call you back to say, hey, can we sub it out for something else? Because again, we could use a generic, but since they're not really generics for these, we'd have to call to get a different brand name for that. So that's one thing to just note with that. Okay, so how we're going to write our directions now that we have our dose up there, or we have the drug name there. Instead of administer, what else could we say? Inhale. Yeah, you could use inhale instead if you wanted to, right? So you could say administer is fine too, right? But I don't want to say you're wrong, but that's just something else you could do instead. There are multiple ways to be correct, right? So inhale, how much?
1 to 2 puffs.
So 1 to 2 puffs. Anyone think anything different? Typically 2 puffs is pretty standard for the most part, right? And again, whenever you put ranges, what else do you have to qualify that with? we have to educate the patient on like, well, when to use 1 versus when to use 2, right? So for the most part, 2 is generally good. And as I said, 2 is nice because the first dose opens them up a little bit, second dose gets in a little deeper and works even better, right? So typically 2 puffs. Yes, sir.
You say like inhale 2 puffs at least 1 minute apart.
You could include that directions as well, or you could just educate the patient, when you're doing your teaching. If you're working in like in an ER, sometimes it's nice because the respiratory therapist will come by and they'll actually do the education. So you might actually order that on the inpatient side to say, inhaler education for the patient. RTs will come down and help out with that, which is nice. They're a good resource for that stuff because again, that's all they do, right? Is just respiratory stuff. So we said, okay, so we have 2 puffs, and that's how often?
4 hours.
Q4 hours as needed. You could do Q4 to 6, no problem there. That's the minimum time between doses though, right? So Q4 is fine. And as needed 4.
Asthma exacerbation. You can't write that dose.
You can say asthma exacerbation, but like what does that mean for the patient, right, when they're actually reading that? You write difficulty breathing, cough, shortness of breath, wheezing, right? So I know those are fine. I'd say cough/wheezing I think is pretty standard for a lot of prescriptions there. Okay. Good. Now, what else do we need to write? So we need refills. So how many refills do you want to give for this patient?
Because this is mild persistent.
Okay. Yeah. So we're going with
Do it that often a week, like 1 times a week.
ideally, but maybe they use it more often than that. I don't know.
How much?
We can't predict, right? Because this isn't as needed medication. So again, if if all of a sudden the pollen really starts to kick into high gear, then all of a sudden he might need it more versus less, depending. If he's out exercising, he may need more. So how many refills do you think would be reasonable? 2? Okay. Now remember, he's also new diagnosis, so that sometimes will come into play as well. You may want them to come back and say, hey, listen, I'm going to give this to you. I want you to start thinking about, okay, how often you're using it. Sometimes keeping a diary is very useful, so I can kind of keep track of that, and then you have them come back. So I think giving a couple of refills is totally fine. If you wanted to do that 1 to 2, I think would be reasonable. That way they can come back and you can kind of see how they're doing. And how about for dispense quantity? Yeah, you can just write 1 actually, because again, the quantity is just an inhaler. It's kind of understood that would be the case there. So you can say 1 inhaler, 1 I think is totally fine as well for that. So that's a complete script, right? So now we have our albuterol inhaler. It's 90 micrograms per dose. Again, you probably don't even need the 90 micrograms on there if you want to be a little bit more succinct. Inhale 2 puffs every 4 hours is needed for cough/wheezing. Dispense 1, refills 2. I think that looks like a pretty good prescription. Round of applause for our friends here. Good job. Yes, ma'am.
Did you keep the MDI and the HFA, or is it just one or the other?
You could do one or the other. If you were to write the 90 micrograms, that also pretty well implies that yes, it's an inhaler. Typically in the brand names is where they have the HFA there. I'd probably just write MDI, albuterol MDI. I think it's pretty reasonable. But yeah, when they had to put the HFA into the brand names there, because when they went through and changed them all out and they got the new patents, that's when they added all that in there. So very good. So what else might you consider prescribing for this patient here? Because we said now he has mild persistent asthma. No, so we want to start considering low-dose steroids. Okay, so would you want to do... Now, do you think this patient here, do you think he needs like a short course of like pulse dose steroids? Short course of oral steroids? What do you think? He's coming into the clinic, is he actually having an active asthma attack right now? Not really, so he probably doesn't necessarily need to have, and again, this is a new diagnosis, right? So he's not coming up with an active issue, so you may not need a 5-day course of steroids or something like that, but you could start him on an inhaled steroid would be a good example of that. Fluticasone. So let's write a script for fluticasone. Who would like to volunteer? And thus we go to the randomizer. Let's see here. All right. Lucky number 28. Does anyone know if you're 28 or not? You don't. I'm going to pull that up and we're going to find out who is 28. That is going to be Miss Jamie. You're already volunteering, but that's okay. There's a randomizer.
I've been chosen.
Yes, you've been chosen. I cannot control the randomizer, unfortunately.
Alright, hold on.
As a wise man once said, it is what it is, and it ain't what it ain't. So let's think about fluticasone, how we want to dose that, what we're going to Give them. We're doing an 8-year-old boy, not a 46-year-old woman or otherwise. You want to think about that? Now, say for instance we were treating, say, an adult patient. Do you think that dose would change for the albuterol inhaler? Not typically, right? They probably end up having the same order. You may say 2 to 4 puffs potentially, but yeah, 2 I think is pretty reasonable for most cases there. So with this, with the corticosteroids, you also have to consider the dosage form itself. We mentioned with albuterol inhalers, they really only come in one dose, the 90 micrograms per actuation. With the inhaled steroids, if you're using these, they will have different doses depending on how much you want to give. So the question is, well, what kind of dose do I want to give this patient? So low dose, we want to start with the lowest dose we have. So what would that be? Dosage forms, we can see our Flovent.
So the 44 micrograms.
So we can start with that if you want to. Okay. And what's the concern with using an inhaled corticosteroid chronically in young children?
So growth issues.
Yeah, there's some concern you may have, maybe some growth stunting associated with that. Again, clinically, I don't know how relevant it is. Obviously, if they are having pretty severe asthma symptoms, I would say that outweighs the risk of any growth stunting can happen there, but that is a concern, right? In which case, what could I use as an alternative if I did not want to use a low-dose inhaled corticosteroid?
Long-acting beta.
Well, again, remember, we don't want to use those by themselves for asthmatic patients. We find there's increased death associated with that. What's an alternative, though? Not a long. You usually don't use those long-acting for a controller medication. Well, what's causing some of that inflammation? Could it be maybe those leukotrienes? So perhaps using a leukotriene antagonist, right? Something like montelukast or singular would be good there. Okay, so anyway, getting back to our low-dose steroids, so we have fluticasone, we have Flovent, HFA. Now, this is good to include the brand name for this one because what's the alternative dosage form or the alternative administration you could use for fluticasone? Nasal, right? So that's Flonase. By writing Flovent, that is again an additional safeguard to show that hey, we don't want to get these mixed up. We don't want the pharmacist to accidentally fill with a Flonase instead of a Flovent, right? So that's good. Also, by putting the HFA on there, it's pretty well understood that yes, that is going to be an inhaler. Okay, so we're going to say how much we want to give. So inhale 2 puffs. So now, what dose are they actually getting? Right, so now they're actually getting a total of 88 micrograms. You have to think about that in terms when you write that. If you said low dose, could you just use 44? Anyone? What do you think? I would say you're probably okay. And again, I'm not just like surfing Instagram or something like that. I'm actually looking up LexiComp, so just FYI. Anyway, I think 88 micrograms per dose is actually pretty good. Again, the other dosage forms we had for the Flovent came in like a 110 and a 220. So again, that'd be more your moderate to high dose fluticasone. I think using the 44 microgram per actuation form and using 2 puffs at a time would be fine. Okay. Again, they're getting a total of 88 micrograms. I just want you to think about what the total dose they're actually getting is. Okay. So now 2 puffs. Okay.
This would be an as-needed basis, right? This is a.
What do you think? Remember, this is going to be a controller medication, right? This is trying to prevent an asthma exacerbation from occurring, so this would not be PRN. This would be a scheduled drug. Now, the question is, how often do we want to give this? Remember I said for most of these long-acting drugs, most of them are BID dosing, okay? So typically, yeah, twice daily would be pretty reasonable for this, okay? So giving 88 micrograms twice daily or 2 puffs twice daily is reasonable, okay? Okay.
makes it continuous.
So do you need to put a duration on there? You don't have to put that on there, right? Inhale 2 puffs BID is reasonable. That's the assumption that they're going to continue doing this until they don't have any drug or it gets DC'd, right? It gets discontinued. So okay, so now what else do we need to write on that script?
Indication. So
You could write indication, right? You could write for asthma, right? What else do we need on there? So we need a dispense quantity, and we need refills, right? So again, those are things you need to have an actually legal script on there, right? Otherwise, the patient may only get one fill and then not actually get any refills on that if you don't write for it. Indication is not required by law, but it's something that's nice to include. But again, if you see a Flovent HFA, chances are it's pretty well understood. It's either for asthma or COPD or something like that. So you could dispense one, and then how many refills do you want to do? Keep in mind, this is a monthly supply for this drug, right? One inhaler should last them for the month if they're getting 4 puffs per day, okay? So how many do you want to give? Do 2, so that way that's how many months in total? Yeah, so you'll get 3 months. Do you want to see them in 3 months? Do you want to see them sooner? Yeah, so it was a new diagnosis, right? So you could say, well, if I want to see them a little bit sooner, give them fewer refills, right? So I would say, hey, let's see how this is working for you. You may need to go up in dose, right? You may need to switch it out, say to the 110, depending on how he's responding to it, especially if you look at his little asthma diary and it shows he's using his inhaler multiple times a day, or potentially, right? So just depending on how it goes. So you could make an argument for doing fewer refills. I probably would not want to say 6 or 11 refills. That would probably be pretty unreasonable for this kind of case here. So two would be fine as well, right? Again, by writing fewer refills, that is just another way to try to compel the patient to come back and see you. Because otherwise, if they're doing fine, the asthma is not being an issue for them, they may say, well, I don't need to go back and see my provider. I'm doing fine, right? Until they need the refills. And that's usually when they're going to come back and come see you. Okay. Very good. Thank you so much. Another round of applause. Yes, sir.
How long would a meter dose inhaler just last?
For that one, that would be a month's supply typically. Yeah, so typically say 4 times 30 days. So say 120 doses would probably be in that inhaler. Probably a few extra, just in case. Sometimes you need to prime the pumps beforehand with the first use, things like that. But yes, sir.
Does that fluticasone urate? Is that something you typically see?
Not as commonly. That is just a different salt form of it. I don't see it too frequently. The Flovent HFA is probably the most common one you're going to run into. Yeah. So any questions on that one? Okay. Let's say as an alternative, what if we wanted to write for singular for this patient? Like, you give the script for the fluticasone, and the mom's like, I don't know about steroids. I'm worried about, I've heard some bad things about steroids. What can I do instead? We said the Montelukast, so how do we want to write that? Any volunteers? This is an easy one. It's just straight oral tablets, right? All right, the randomizer will speak again. It'll speak for you if you won't speak for yourself. Number 40 is Miss Emily. Where are you at? There you are. All right. Come on up. So let's write for Montelukast. There's a patient here. How are those books organized? Are they by organ system or alphabetical? Or?
Yeah, it's like cardio.
Okay. Be easier for the alphabetical if you knew what drug you're looking for, but it is what it is. That's true. Yes, you do have an index.
Well, because sometimes it's like everything is short, like endo.
Okay, so we have our drug here, so Montelukast singular. So the question is, we have a couple different tablet sizes available to us. How much is good for an 8-year-old? Okay, so why 5 milligrams? There you go, perfect. Yeah, so good. So you can write 5 milligrams. Now, what's specific about that dosage form? Yeah, so you can include that if you want. Any of the 5s are going to be a chewable tablet anyway, but you can say 5 milligram chewable tablet is good. Is that reasonable for a child to use a chewable? Mm-hmm. Yeah, just like your Flintstone chewables and things like that. Usually they're flavored such that it's not super gross for the kid. So it should be a little easier to swallow, so to speak. Okay, so we're going to say oh, good. Yeah, so right, being specific and saying actually chew it, right? Then remember, so chew 1 tab by mouth daily. Now, when do you want to give singular? Morning, night, lunchtime? I would tell you, typically Montelukast is given QHS, right? QHS means bedtime. Why that is probably something to do with leukotriene, synthesis maybe being higher at nighttime due to circadian rhythms, things like that. Who knows? But that's one of those drugs you'll see usually given at nighttime. So yeah, so you would say chew 1 tab PO. Now actually I probably wouldn't include the daily. You could just say QHS for that would be fine. Yeah. 1 tab PO QHS for asthma, and then how many do we want to dispense? Yep, 30. Why is it good to write out textually the quantity? Yeah, people who maybe want to abuse that singular for that sweet singular high. No, that's not usually a concern for that particular drug, but other things certainly you can consider that, right? So one thing I was giving a talk recently to an internal med family practice clinic, and they were saying that they're seeing a lot of abuse of gabapentin, right? Gabapentin, anyone know what that's used for? Neuropathic pain, right? So people who are maybe using opioids before are having a hard time getting it due to the restrictions due to the law. They're turning to non-controlled substances to try to get their fix, right? So Lyrica or pregabalin is actually a controlled substance, so that's harder to get a hold of than gabapentin. So they'll be getting like hundreds and hundreds of capsules, and they could doctor that script. If they only had 30, they could write themselves 300 pretty easily, right? But so that helps to safeguard yourself a little bit there. Good. So we're ready for 30. Refills 2. Again, we talked about that being fairly reasonable. He signed it. Any questions on that one? Again, a round of applause. Fantastic. Thank you so much for appeasing the Google gods of randomness. But okay, so let's go to another case here. Are these helpful at all to kind of work through it this way? Okay, so let's go to another case. Let's see, this one's a little more dramatic, which I like. So this is coming from the emergency medicine case files. If you notice the authors here, you want to know who that guy is? Yeah, he's the Roche guy. Actually does Roche review. If you go to PAEA or if you go to like JAPA or things like that, he's usually at those conferences. So usually trying to get people to sign up for Roche review. But yeah, sometimes it's good to look at the authors because you may start to see like trends in certain things. Be like, oh yeah, he's an emergency medicine guy. Anyway, so let's see. You're working at the ER. It's 3 a.m. and of course all the fun stuff comes in at 3 a.m. Right? Paramedics call to let you know that they have a 33-year-old woman with a history of asthma coming in. She's brought in, identified she's in severe respiratory distress. She is working very hard to breathe. Sweat's pouring off of her face. She's heaving. She's tripoding. Anyone know what it means to tripod? So I'm kind of leaning forward, using hands on their knees on the bed, and they're just, right, so they're breathing very hard. And then I love this sentence here. Her efforts are ultimately futile as her consciousness slips away and she becomes apneic. Like, wow, that is dramatic if I've ever seen it. So your initial assessment would be what? And again, it's right here, acute exacerbation of asthma. So boom, you already got your diagnosis. Easy peasy. So the question is, what are we going to do for this patient? Right, so first off, you got to worry about which 3 letters? A's, B's, and C's. Obviously, what is taking a hit at this point? The A, right? So actually, the B is really the big issue because she has tired herself out to a point where she is losing that ability to kind of keep that pace up. So again, the worry is she's going to become hypercapnic very quickly. She can tank very quickly due to the apnea. So we're going to want to intubate this patient, okay? So let's say, what would we want to intubate with? So I'm going to call on someone to come up. We're going to write a couple of orders because again, these are a little bit faster because these are inpatient or these are actually like hospital-based orders here. So we're going to work through it. Let's think about this. So let's go ahead and call on somebody. Any volunteers though, perhaps? My emergency medicine junkies. Nobody? Okay. Oops. Let's go back. Number 51. It's going to be Rena. Where are you at? Oh, there you are. All right, come on up. Sometimes it's hard when you guys have moved rooms. I lose track of you now. Okay, so let's think about what kind of meds we want to order for this patient here. So just based off the case that we have, we said we want to intubate this patient. Now, do you want to do this as a slow process? No, you'd likely do this. It's a rapid process, so it's a rapid sequence intubation. Okay, so what kind of meds do we want to think about for this patient? So we could use etomidate, right? Etomidate is going to serve as what? Our sedative, right? So good. Remember, we want to have our sedative. But thinking back real quick, what about our pre-medications? Anyone remember what we talked about there? Atropine and lidocaine, right? So lidocaine is used for which kind of patients? Head trauma patients, right? People you're worried about increased intracranial pressure, right? So this could be, it's Miller time? Just kidding. Sorry. It's a little early, but I guess it's 5 o'clock somewhere. No. Right, so lidocaine, probably not this patient here, right? We're probably not worried about her brainstem herniating anytime soon, at least from this asthma attack. What about the atropine? They're bradycardic. If they are young children who may be getting succinylcholine, you're worried about them vagling down. This patient, though, could benefit from atropine because of what? She's having a lot of nasty secretions, and that was impeding her ventilation. That could be one thing you might think about. But let's say not in the usual course of things would an asthmatic patient get atropine for that. Okay, if she was bradycardic, then that would be another situation. But so we don't need any pre-meds, right? We made that assessment. Getting into our sedative agent. Now you said etomidate, which would be a reasonable choice, right? How does etomidate affect the cardiovascular system? It doesn't, which is great, right? It's very neutral in terms of heart rate, blood pressure, and all that kind of good stuff. What else could we use though that we talked about a little bit ago? Ketamine could actually be a very good option for this patient here, right? So let's talk about ketamine, see what kind of dose we would use to intubate this patient. And again, because we don't have a weight available, it's an adult patient, we're just going to go off kind of more standard sort of dosing, okay? I hope ketamine's in the book, otherwise I wanted to give you the answer. It's no fun. It is in there? Fantastic. So I'll have you write our intubation meds, and then we'll go on and we'll talk about the asthma meds as well. Okay, so 1 to 2 milligrams per kilogram. As just said, we don't have a weight. What's kind of a typical weight for an adult female, if you just had to guess? 70 kilos, which is roughly how much? 130 pounds. It could be, and again, sometimes you have to just look at a patient. You don't have a scale available. You just kind of have to thumb it. I'd probably say between 60 and 70 kilos. Sounds pretty reasonable. Does everyone kind of agree with that, right? Healthy adult female. Okay. Could be a little less, could be a little more. Who knows, right? So let's go ahead and say let's go 1 mg per kilo going off, let's say 60 kilos. Okay. Okay, so what are we going to do? How much? We're going to do 60 milligrams? Okay. Let's do it. You said 1 to 2 milligrams per kilo, right? So let's go with 1. Let's start with that. See how she does. Yes.
Can you just elaborate a little bit why we're going with ketamine instead of etomidate?
So I'm just using this as an example of the case where ketamine provides additional what benefit? Bronchodilation, right? So this patient is obviously in a very severe asthmatic exacerbation, so we can go ahead and give her something as additional bronchodilating sort of effects here, right? So again, we're thinking in the ER sort of setting. So are we thinking about like having like multiple doses of things being given? Are we thinking about, continuously running medications? Not typically, right? Usually in the ER, you're thinking like one and done sort of drugs here, right? So with RSI, we're going to go ahead and give ketamine as our sedative. So we say ketamine, and then what else do we need? And honestly, these you actually can write just in one line because typically you're writing for multiple orders at one time. So we can just say ketamine. How many milligrams do we want to give? We go 60 milligrams. Okay, what's our route? We can do IV, so we'll assume the patient has an IV. And then what's our frequency? Okay, so you want to administer it, why over 1 to 2 minutes? Anyone know? You can actually end up seeing pretty big jumps in the heart rate and blood pressure. You're going to see that anyway when you give it over that 2 minutes, but you can sometimes cause kind of really big spikes, and you want to avoid that. So you can write that in your instructions as well. IV over 1 to 2 minutes. Now again, do you want push there? Because you're specifying the time you actually want to give it over. So some people still consider 1 to 2 minutes push, but usually if you're specifying a time, you don't necessarily need to have that push there. Okay. Push could be anything like a couple seconds to a few minutes, but it's a good thought, right? So okay, so is that over 1 to 2 minutes, and how frequent do we want this to be given? You do once, yeah. So you could just write once if you wanted to. You could say maybe PRN for sedation times 2 doses, maybe. Sometimes we'll do that for like a procedural sedation. But in this case here, we're hoping that just the one-time dose is going to be good, so we're going to get that intubation done the first time, right? So you could say 1 to 2 minutes once, and then for this case, you could say like for RSI or for intubation, that could be your indication. For sedation, that's totally fine as well, because either one of those would be good. I'm sorry to keep making you erase stuff. And then, right. Again, there's a lot of ways to skin the cat, as it turns out. Okay, so you're going to see depending on your system and how things are set as defaults, it may do other things. So okay, what next do we want to write for? I guess I'll let you sit down. Okay, round of applause. Good job. Okay, so I heard someone say paralytic, so let's see who's going to be writing our paralytic for us. Number 10. Did I call him 10? All right, Kelsey, where you at? Like facial blindness. There you go. All right. So who's got an idea about what kind of paralytic you want to use? You want to use rocuronium? Why rocuronium? Okay, so I don't have to worry about malignant hyperthermia potentially. What if I had, like, say the family member was there and I say, hey, do you have any history of bad reaction to anesthesia? And they're like, nope, not that I know of. Do you still give rock? Okay. What else do you have to worry about with rocuronium? I'm sorry, not with rocuronium, but with what's our alternative to rock? Sux, right? Succinylcholine. Okay. So what are some other risks with succinylcholine? It's pretty fast acting, so I don't necessarily worry about reversing succinylcholine too frequently. But what are the other concerns I think about succinylcholine? So malignant hyperthermia is one, but that's pretty remote chance. What are some more likely things a patient may have? So you can cause bradycardia, but so if she's bradycardia to begin with, maybe not a great idea. But if she was, I can give atropine to overcome that. It's no problem. What are the other contraindications? Hyperkalemia is a big one, right? Because again, this is activating the muscles, it's causing a fasciculation, and then leads to paralysis versus rocuronium, which is just a non-depolarizing neuromuscular blocker, right? So hyperkalemia would be a contraindication. What else? What are the other big ones? Remember the burns, crush, denervation injuries, right, within the past like 2 or 3 days or so? Remember that being an issue? Does this patient fit that category? No, so she wouldn't have any contraindications there. Presumably she does not have hyperkalemia due to the fact that she's otherwise healthy that we know of, so I would not worry about it from that standpoint. Those are the big ones, right? So could this patient get succinylcholine? Theoretically, yeah, she could, right? Are most of you going to give succinylcholine? Probably not, right? Because why? Rock is just easier. You don't have to worry about all that stuff. You can just give rock, right? So a lot of people will default to rocuronium, so let's go ahead and go with that. Let's see what we can do for that one. Let's dose our rocuronium for our patient here. Anyone know of a good dose for etomidate if we were to use that instead of ketamine? Yeah, so 0.3 to 0.6 for that patient there. She's 60 kilos. Usually about 40 milligrams of etomidate is good for most patients. So 40 milligrams is a pretty standard dose there. So we got rocuronium. No, you're writing your brand name on there, Zimuron. What's the brand name for ketamine? Anyone know? Don't write special K on your orders in the hospital. People are going to get real concerned real quick. Yeah, Ketolar. Yep. How much do we want to use for this patient here? So rocuronium is another easy one in terms of dosing. How much are we going to give? 1 mg per kilo, yeah. So we can go ahead and just do how much? Good, right? So we're going to do 60 of ketamine. We're going to do 60 of rocuronium. So we have our drug, we have our dose, we have our route. Now, do I need to give rocuronium slowly at all? Yeah, that one doesn't have any real concerns with it from an administration standpoint, so that one can be given with impunity. So that one you could write IV push. That would be acceptable. Because again, this patient's like actively apneic right now, so presumably the RT is going to be doing some bag mouth vasc work there to try to aerate the patient. But again, we need to get her intubated now, so IV push is a reasonable route for a lot of these drugs here. Good. And then how about our frequency? Just once, right? So good. So, and again, what would be the order of medications I'm giving here? Sedative first, right? You never want to paralyze a patient without sedative on board. So ketamine first, and then your rock can give. Okay, good. So now we have our rocuronium. Thank you so much. You may sit down. And we want to go ahead and start thinking. Let's say we got her intubated. First try, no problem. You look like a rock star, right? So let's think about what we want to do for the asthma standpoint here, right? So what's the first drug we want to give to this patient? We can start with albuterol, right? Pretty straightforward. We have an asthmatic patient. Let's open up those lungs a little bit. Let's open up that smooth muscle. Let's give albuterol. So now we're going to see how to write an inpatient order for an albuterol versus an outpatient order. So who would like to volunteer? Again, still nobody. It's interesting. 54. Who's at the bottom of the list here? Mr. Cupkey. Come on up. Yeah, so we're going to write for albuterol. So typically if this patient were coming in and maybe was not in such a dire state, you could start out with, a pretty typical dose of albuterol. And in this case, would I give it via MDI? Would I give it via nebulizer? What do you think? Probably via nebulizer. That's what you're going to see most commonly done in a lot of cases there. So we could write for albuterol. How much would you want to give this patient? 10 to 15 milligrams an hour. Okay, so that would be a continuous albuterol administration. Do you think this patient fits the need for that? You don't think so? She's being intubated for status asthmaticus. Yeah.
1 3 milliliter unit dose, nebulized 3 to 4 times per day.
So 1 3 milliliter nebulized dose. So 3 mL is how many milligrams? That'll depend on your concentration. So that's another good point to note here with albuterol, is that sometimes it'll have multiple concentrations you're going to find there. So typically when it's given as like a 3 ml neb or something like that, typically it's between 1.25 to 2.5 milligrams, depending on the concentrations that they're using here. In the hospital, we'll probably use a little bit more concentrated format. So that way you don't have to think about it. On the inpatient side, just write the milligram dose you want to give. Okay, so a typical dose I'd give for a patient presenting with an asthma exacerbation would be between 2.5 to 5 milligrams nebulized. Okay, you could say Q15 times 3 doses would be pretty reasonable. Okay, Q15 minutes, right? Because we don't want to be specific with our units here. However, this patient is so severe, she probably will benefit from continuous albuterol administration. Okay, so that's when you get into the per hour sort of dosing there. Okay, so this patient, you said between 5 and how much? 10 to 15. You could even do between 5 and 20 is actually pretty reasonable doses that I've seen there for continuous utilization. So let's go ahead and write for continuous albuterol. So in this case, you denote it as continuous nebulization. You write continuous neb. People know what that means when you're talking about albuterol. And how many milligrams per hour do we want to give? What do you think? Do we give her start with low dose and kind of work her way up, or do you want to hit her hard and then come back down if you need to? We're in the ER, so what do we want to do? Hit them hard and come back down, right? All right, so let's start off. Let's say this patient's intubated. She's pretty severe, right? So let's go ahead and start off maybe with 20 milligrams an hour. Now, because of that, the route is kind of inferred for a lot of those orders there, but if you had to write a route, you could say inhalation will be fine for that. So yeah, so albuterol continuous neb inhalation, 20 milligrams per hour. Do I need to put, say, a frequency on there? Yes, ma'am.
When we put 0.21%.
So when you're on the inpatient side, you don't have to worry about that concentration quite as much because, again, the RTs are going to be coming to make it, or pharmacy will make it, and that way they'll administer it, right? So you have to think about that less on the inpatient side than you would, say, on the outpatient side. Typically, though, you would consider the concentration you're administering there. I frequently see the 0.083% is used pretty commonly for an outpatient nebulizer. That way they don't have to mix it with anything. It's just ready to go by itself. But this case here, we don't need a frequency because it's a continuous med, right? So because you say per hour with no duration on it, it's just assumed it's going to run continuously until you come or someone else comes and discontinues that order. Does that make sense? So writing albuterol, continuous neb via inhalation, 20 milligrams an hour, that's a fine order. That's all you need right there. Okay? And then if you need to, you can scale back down, go to 15, 10, and then you can get them on a more intermittent sort of nebulization schedule there. Now, what else could I give along with this? Thank you. You may sit down. Very good. You want to do steroids next? Okay, good. Who would like to volunteer to write our steroids? So number 36 is Mr. Evans. Where you at? Come on up. Where's he at? Okay, looking at dosing. Okay. So what steroid would we like to use? We use dexamethasone? That's one way to do it. What else? Now think about the route that we want to give for this this patient here. Yeah, so we want to definitely do parenteral because again, it's going to be kicking in a little quicker than if it was an oral dose. That's one thing to consider. I will tell you, most often I typically see methylprednisolone being used much more commonly for that. So let's go and write for methylpred. Now, one handy thing to remember about methylprednisolone is that there's actually two formulations of it. There's a sodium succinate, and then there's a sodium acetate. The acetate is typically the longer acting depot form of it, so if you see that, be wary. That's not the one you want. You want the succinate. It's going to be the shorter acting formulation that's typically for IV administration. Okay. You'll notice that when you're looking at the formulations, you'll see the methylprednisolone has a couple different salts. Again, you want the shorter acting one. How much do you want to give this patient? Yeah, so you see a depot medrol, means the depot means what? So yeah, it's usually like an IM, like long acting formulation. That's not the one you're looking for, right? It's the acetate.
Solumedrol?
Yeah, so solumedrol is a good one, right? That's the one you want to go for there.
So if we want to do like 250 milligrams?
250 milligrams per dose, or how often? Like, what do you think?
It says 10 to 250 milligrams IV, do 4 hours.
Ooh, 10 to 250 milligrams. That's a pretty wide range there, right?
Yeah.
Oof. So I would tell you, when you see big doses like that, like 250, things like that, that is typically more often going to be for like pulse doses for like maybe you have like a rheumatoid arthritis flare up or something like that. Typically, you want to keep it more close to kind of close to the prednisone dosing. And you could do like 1 per kilo. And usually for someone who's severe like this, we're actually going to do it multiple times a day, as you'll see there. So I'm trying to find if there's a good. And I will tell you in the ER, say you had someone who's presenting with anaphylaxis, they would probably get a one-time dose of the 125 as a kind of a one-time dose, and then you might put them on, say, like a 5-day course after that once they leave. But we're going to be admitting this patient right to the PICU, so we're going to put them on an order that's going to be kind of lasting a little bit longer for them. So what I would probably say for a patient like this, what do you think about dosing?
It says here that for acute asthma exacerbation, you can give a 240 milligram IM injection.
Yeah, so an IM would more imply that it's just like a one-time dose versus something you're going to be doing continuously. So if I was to put a patient in the PICU, I'd forego the IM and just use IV. And so I'd probably do like, say, 1/2 to 1 per kilo Q6 hours, okay? So the goal of that is to get that inflammation under control. By the time they're extubated, we're weaning them off their other stuff, they're off the continuous albuterol, then we can get them onto oral steroids, right? Because the goal is always to go from IV to oral whenever you can. So
Like 30.
you're going to do 30, and then how frequently?
Say hourly or 4 hours?
So in this case, it will not be a continuous infusion, but it'll be kind of continuously running, so to speak, so an intermittent dosing. So Q6 is pretty often given there. So you can say 30 milligrams Q6. Again, let's not forget our route. We said what route we're using.
IV.
Good. Yeah, so IV. So 30 milligrams Q6 hours, and then we could just leave it like that, right? Because again, you're going to be coming in and assessing the patient, deciding, okay, well, can I switch them over to oral? Maybe at some point you'd say, okay, let's go down to Q12. Maybe I'll just go down to daily, and to the goal of getting them on like oral prednisone or something like that. Okay. In those cases, someone like this who might be in the hospital for a couple of days and still need oral steroids to go home on, you may want to consider then tapering them off at that point because it's getting close to a week. Okay. Very good. Thank you so much. You sit down. So that kind of makes sense there. And again, how much per day of methylprednisolone is she getting on a milligram per kilogram basis? So she's getting a Q6 hours. That's 4 times a day. So she's getting 120 milligrams, right? And that's, we said her weight we're estimating to be about what? 60. So she's getting 2 milligrams per kilo per day. And if you look at the asthma dosing, that's pretty consistent with that, right? If you were to say, send this lady home, say she came in less severe, to send her home on a 5-day course of prednisone, it's between 1 to 2 milligrams per kilo. Usually max it out at 60. For a severe patient like this, you could probably even go up higher than that. You could do 60 Q6. I've seen that in some cases there. Because again, she's that severe, she may need a little bit extra anti-inflammatory action there. Does that make sense? Very good. What else could we give this patient? Want to do fluids? You want to volunteer to do fluids? No? Okay. What else could we give them? You guys know how to do fluids. How much, what kind of fluids would I give this lady? Normal saline? You want to do D5 normal? Why D5? Yeah, she's probably going to be NPO, right? Because she's not going to be eating while intubated, right? She's not probably going to fit that category where she needs like parenteral nutrition. So you could do D5, and then what kind of sodium content would you want to add to that? Yeah, you could do normal saline, you could do half normal saline. Either one would probably be fine there. Again, I like normal saline because you're less likely to cause that iatrogenic hyponatremia. Yes, exactly. So, and what kind of rate would you want to put her on? Probably do like 100 mLs, 110. Based on the 4-2-1 rule, guess how much? 60 kilos we're estimating. 100 mLs an hour, right? So again, 100 mLs, 125 mLs an hour would be totally reasonable. That's a good thought to put the lady on fluids. Good. What other drug could we use? I need something else to help just relax that smooth muscle there. What'd you say?
Benzo.
Well, benzo, she'll probably be on a benzo probably for sedation from that standpoint. The ketamine might be enough of itself if you want to do a continuous of that. But let's think about something else for the bronchodilation. Is where, yes ma'am. Yes, perfect. Magnesium. Would you like to write the magnesium? If you'd like to be so bold. So what form of magnesium are we going to use? Magnesium citrate, gluconate, sulfate. Mag sulfate, right? If you're using IV magnesium, it's magnesium sulfate. Mag citrate's actually a laxative. That's what I call the green rocket. Once you take it, then you're heading to the restroom like a rocket, right? Yeah, so no mag citrate for this patient. She probably won't appreciate that. So how much magnesium can we give this patient? So this is actually an interesting one because we can do a bolus followed by a continuous infusion. You're going to get a 2-for-1, which is fun.
So it says 4 to 6 grams loading dose, then 1 to 2 grams continuous infusion.
That's for the asthma indication?
Oh no, that's pretty, sorry.
Yeah, so again, think about your indications here, right? Because you were looking up eclampsia, preeclampsia. Very different indication, much bigger doses of magnesium are given to those patients there, right?
Yeah. 2 grams IV.
Mm-hmm. Perfect. Yeah, so let's go ahead and do the bolus. And so I'll tell you for pediatrics, typically we'll hit them with 50 milligrams per kilo. So if I were to take that for my 60 kilo patient, what does that turn into? 50 times 60 would be, yeah, it'd be 3 grams. For adults, you cap out at 2 grams though, right? So again, even if you calculate it to be higher than 2 grams, you still want to cap out at 2. Okay. It's good to denote the salt you're talking about. And just as an example for the methylprednisolone, you could also write methylprednisolone succinate just to make sure people know that you're talking about the short-acting form and not the depot form. Because again, that's another common error that can occur in the hospital if you weren't being careful. Okay. So we said magnesium sulfate, 2 gram IV bolus. How long do you want to run that over? Okay, so yeah, good. So we want to make sure we include 20 minutes. Why is that? We're at the hypotension if you go much faster than that, right? Now, if this patient was in torsades and they're actively coding, how fast would you give it? Yeah, when you hit your ACLS, you're going to just push it, right? Because again, that patient's not actively circulating; they're dead essentially. So give it to them, push. Here for these patients, yeah. So we can say, or you can say over 20 minutes. Yeah, because you can say infuse over 20 minutes if you wanted to. Good. So you have that, and then we could do a continuous infusion afterwards. Did yours have dosing for that?
Just do the 4-2-1 rule?
That's for more your maintenance fluids. You wouldn't want to do that with an electrolyte like this. And again, I'm looking at mine. Doesn't have a specific thing for adults. Typically, though, you can go like between 25 and 50 milligrams per kilo per hour. So you could say, let's just do like say 1 gram per hour. So you'd say followed by. And when you're writing this like in your electronic medical records, there's like options to like link orders together, so that way the nurse can't accidentally do both together or do one before the other. So that way it helps to keep that succession going there. Say followed by, you say magnesium sulfate again. Now, how could you abbreviate magnesium sulfate? MgSO4. Do we do that in the hospital? No, why not? Why not? It's a do not use. Know why it's a do not use? Because it used to get mixed up with morphine sulfate. People write MSO4. So imagine if you meant to give magnesium to this person instead of giving morphine. Maybe not a concern if she's intubated. However, for someone who's not, that could be a bit of a problem there, especially if I'm giving 2 grams of morphine. What person's definitely not going to be breathing at that point, right? What's a typical dose of morphine for a patient for pain? Like 5 milligrams, right? An IV dose. So if I give her 2 grams, the person would be pretty dead. Good. So you say 1 gram. So again, you want to write your rate though. So 1 gram per.
Hour?
Yep. So very good. It's 1 gram per hour. And make sure you include your IV in there somewhere, so that way they know which route you're giving it by. Okay. And that would be pretty much it. So that way you get your bolus first over 20 minutes, and then they put them on a continuous infusion afterwards, right? And then you can titrate that drip to see how much you want to give them. If they weren't really responding well enough, you could get them bump that up to maybe 2 grams per hour, whatever you like. All right. Thank you so much for volunteering. Good. So is this useful? Do you think you have any questions I can answer on how you write these orders? Notice how the hospital orders are a little more succinct, a little bit more self-contained than say like the prescription orders for outpatient use. Right, so you see a little bit of difference there. Any other questions? Was helpful, useful, maybe? Kind of just focus on asthma, but I think it's good to talk about the respiratory meds. The technique is so important. So please, if you don't have someone like the RT educating your patient, don't rely just on the pharmacist to educate the patient. Like you need to be that person. Make sure the buck stops with you, so to speak, and make sure you educate them well on how to use that. And again, remember the teach back method. What is that? Anyone know? You have them, and again, they can actually show you. So if you had like something like a fake inhaler, like a dummy inhaler, they could actually demonstrate that technique back to you to see how they're doing it. I don't know if you remember, but there's that GIF from House where he was like, "Well, show me how you use your inhaler," and the lady was like, like, well, obviously that's not going to work. But you can uncover a lot of good non-intentional non-compliance that way by having them basically kind of repeat back to you what they do. Okay. Any other questions or anything I can answer? Sorry I didn't get through all the cases, but I think this is pretty valuable to have a good outpatient and inpatient sort of thing there. If nothing else, I will see you guys next time.